to talk through care planning from the folks at Southern New Hampshire Hospital and at Week. So we kind of went to both ends of the state for you today, came together in the middle. And thank you all for coming here in the snow and braving the weather with us. So just our disclosures, none, and welcome. So my name is Adelaide Murray, if you are new here. I work for the New Hampshire Center for Excellence, which is a project of the Community Health Institute, JSI. We work with the Bureau of Drug and Alcohol Services and other partners to facilitate communities of practice such as this. I facilitate the substance use disorder treatment and MAT communities of practice. Half of my body, as I've been calling her lately, is Melissa Schammel. She facilitates 2 other communities of practice where I support her, and she's going to have a little baby boy any day, and so please send me good wishes and her good wishes. Because I don't know what's going to be more painful. And then I also... I never had a child. So Reka's in the back. She helps us as well with everything, and she'll be helping me a little bit more as Melissa's gone. And I'm also going to bring in our colleague Hannah, who some of you may know. She's great, and you'll love her. So we're also joined by other members of our planning team. We have Lindy joining us from VDAS. We have Ann Brannon, who's a consultant working with us, Regina Flynn, also from VDAS, and Peter Ames, who is so kindly filling in for us, representing the Foundation for Healthy Communities. I think that's all. Peter Mason is in Honduras, so also feel badly for him, because he is obviously not enjoying his day as much as we are. So the purpose of the MAT-COP is to promote and support the successful implementation of an integrated MAT approach in healthcare settings. And I think we're really going to be talking about this today, kind of that integration and that coordination and how all these pieces work together in practices. So I'm excited for, like I said, for our presentations today. A reminder about resources, if you don't know or are new or you forgot, we have our Google group, which is a really great resource to ask questions of people, share articles, share events that you think will be interesting to the group, or you have a question of the group that you want to ask. If you are not a member of that or you're having trouble with it, just let me or Melissa know, and we'll put a star on your name so I remember to follow up with you. We also have all of the resources from today and other resources posted on our website. So we record these sessions if you want to go back and listen to it. We have the slides for the day up there, and we also have the handouts that we provide up there as well as other things like the MAT guidance document and the MAT quality planning tool, lots of good stuff there. And then always the Center for Excellence is available should you require personalized technical assistance. So you want to talk something through more on a one-on-one case, or have someone come to your practice, give a presentation, talk through workflows, that kind of thing is all available through TA. If you don't know how to submit TA, ask any of us, and we're happy to answer. So our objectives today are to identify the key components and team members involved in shared care planning, analyze care planning processes used for varying patient care needs and practice models, and then apply those techniques and processes within their own practice and patient context. So you all have a really big sheet of paper with you today. We're going to do a little bit of drawing of our teams and of our connections, and I'll walk you through it. No need to get nervous. We won't hang them up on the wall and have a critique, but it'll be a little bit of getting our hands into it, which will be good. So I think with that, I'm going to hand it over to Ann, who will provide kind of our overview to get our feet wet before we dive in to those really juicy patient use cases. Here's a clicker for you.
You know what, all I have to do is hit it when I want the slide?
Yes, the arrow.
Okay, perfect. So shared care planning was a topic, I guess, that I kind of understood a little bit on a 30-foot level, but doing my research to prepare, I've certainly learned a lot more about it. So objectives for today are to define a shared care plan, identify goals and benefits of a shared care plan for the team and for the patient, determine members of the team, discuss components of shared care plan, and we'll probably spend a little bit of time identifying some of the challenges of implementing a shared care plan. So sort of the strict definition of shared care plan is from the Agency of Healthcare Research and Quality, but really more on a practical basis is sort of thinking about it as like a living document that kind of crosses boundaries of collaborating clinicians and aims to achieve shared communication, collaboration, and patient-centered treatment. One thing, when I was doing this, before I was practicing out loud, saying shared care plan is a little bit so I've been finding myself stumbling a little bit, so I apologize for that. But the other thing, sort of initially, when I started looking at this, I felt a little overwhelmed about thinking about how I was going to present an idea to all of you that you were going to create this living document that was going to cross these boundaries, and how working in a very siloed system here in New Hampshire, how just monumental that would feel. So I think one of the things that we can think about is really thinking about what are the principles of a shared care plan, why they're important in patient care, and probably for team-based care as well, and then thinking about maybe some first steps or some thoughts about how we can incorporate some of the principles in a shared care plan. So some of the principles are developing shared vision and goals in shared language, and at least for me, my experience has been, in organizations that are either new to integrated care or just start, have some integration of care, or more of a team-based environment. And one of the things that I definitely know I've struggled with is sort of recognizing other people's skills and understanding sort of what they do. And we don't use the same language sometimes to describe the same things. So that is one of the benefits of shared care planning. It combines the patient's medical and behavioral health plans in the same place, facilitates communication between all team members, it promotes family and patient engagement as well, allows all members of the team to access information in a timely way, and it also enhances shared responsibility and shared accountability for care. Thinking about who's on the team, the list is really long, and I suspect that there's probably omissions on my part. But certainly not all these people need to be involved in every patient's care. But spending some time to think about, who does need to be on the patient's care team and why. And at least in my role as nurse care coordinator, I would say some of the things are like, pharmacist probably doesn't need to be involved in every patient, and on every patient's treatment plan, but maybe your patient has either had some issues with diversion or issues with non-compliance. Maybe they are on Vivitrol, and part of what you're going to have to do is sort of organize the care around making sure their injectable medication is available, or even now that we're seeing more Sublocade. So in those cases, maybe that would be a really good reason to involve the pharmacist. We had a patient once in Concord that was treated after having a motor vehicle accident. She was started on buprenorphine while she was in the hospital and came to us in the clinic. Pain management was something that we were talking about, and the provider that I was working with at the time was using her buprenorphine to try to help manage her pain as well. And she was seeing a physical therapist, and in that case, we really recognized that it was really important to get some feedback from the physical therapist for a couple of reasons, because we wanted to make sure that her pain was well managed so that she could participate in her physical therapy, but also recognizing that if there's some things that the physical therapist is recommending to help her manage her pain at home, that maybe we can reinforce that when she comes into the office with complaints of pain. So trying to figure out with each patient sort of who is on the care team. It isn't always easy to identify, even with a list like this. And sometimes when patients first come in, we don't get the whole story, and over time we find out that they're seeing this person or, had been referred here, but not seeing the patient. So really involving the patient also is a great way of trying to determine who's on the team. The patient's at the top of the list, and one of the recommendations with the AHRQ was to really have a period of time where you sit down with the patient and you really talk to them about shared care planning, why it's important, and why your team is choosing that approach for them. It gives them an opportunity to understand who the people are on their care team, You can explain a little more about what their role is and how they'll be involved in the patient's care. But it also gives you an opportunity to hear if the patient has any concerns about that, or who does the patient consider on their care or support team, and make sure that the treatment team can involve those people as well. Once you determine who your team is, the next step would be sort of determining who is the general contractor of the shared care plan. And I think at least in some of the teams that I've worked in, that's very clear. More of the medical-based models where I've been working with just one provider, or maybe a primary care office, it isn't always easy to know who that is. Not everybody has every role, but it's not easy to tease out in a medical record sort of what the patient's plan of care is always, but it's still something to think about, even if you are a provider who's working on your own. So what does your team look like, and what would be reasonable for you to think about sort of taking some next steps? So if you are an independent provider, maybe a LADAC that works in the community, or primary care provider, you probably have very little or no support in your office, so it's just you. Thinking about a document like this and trying to incorporate a whole team, I'm sure would feel extremely overwhelming. We hear a lot in the community of practice, but also in some of the ECHOs that I've participated in, how challenging it is to engage other providers in any kind of care coordination. So thinking about it from that perspective, you are it, so you're going to be the general contractor. But even the idea of, if you don't do it now, sitting down with the patient and talking about shared care planning, even though you don't have any, other members of the care team available in your office, sitting down talking about that and the importance of it, and really asking the patient to, weigh in on who should be included in their care. Maybe they're a healthy, young lady, and the only thing that they do is to come and see you, and they're doing okay. Maybe it's not that important right now, but having had that conversation, even if there is resistance or there isn't somebody that you feel like could, is needed to be included in the team, then the patient has that seed planted, and the idea would be that, if we need to, who do we include? So maybe 4 weeks down the road, you've had that conversation, and maybe they're struggling to remain abstinent, and then now they're considering that maybe they would go for the medication evaluation, or maybe they got stopped for a DUI, and now, the criminal justice system is involved in being able to circle back around, and bringing it back to that shared care planning could be really helpful. Maybe you work in more of a clinic or a treatment model, so some of the care team is probably on-site or pretty accessible to you. Maybe you guys have even started to, if you don't have a document, but maybe you have a way that really has been allowing you to share information and collaborate on treatment goals. And maybe for you, the idea of shared care planning could be sort of certainly honing those things, or maybe creating a document or a place in the medical record, if you have a shared medical record, that you can all go to for information isn't that much of a stretch. But maybe thinking about increasing your circle of the shared care plan to include some of the people in the community who you don't always have contact with and don't necessarily always include in the patient's care plan. And then lastly, which is the environment that I've worked in mostly, is, big healthcare systems. So, one of the healthcare systems that I worked in had pretty much all of this on site, even drug court. But even when all of those things have a shared medical record and we're all within the same vicinity, it's still really difficult to really collaborate and include sort of the whole person care or patient-centered care, thinking about all the providers. So if this is the organization that you work in, maybe you already have a shared medical record and you already have a document that you've created that you can go to. But really thinking about how to solidify some of those relationships, or really going back to that list of who's on the team. That's going to change, depending on, different patients, and who do we need to include now, and how do we include them? Some of the strategies that I found helpful was just even building things like when I worked in an organization that had drug court, I would send a weekly update. You know, who on the list did we see this week? Did they have any changes in medication? Are there any follow-ups? And one of the reasons was because I learned early on that drug court was a great support. I mean, once we started to kind of bridge those relationships, they would help with a lot of things. They would reinforce appointments. They would have the patient, I'd call and say, I've been trying to get hold of so-and-so. They haven't called me back. They'd have them call back while they were still there. We even had them sometimes do witness dosing. We had difficulty bridging people sometimes on naltrexone, and the weekend would come, and they wouldn't, they'd not take their naltrexone, and then they'd use, and they'd come back to the appointment, and they were back using again. But sometimes we could set it up Monday through Friday when they were at drug court. They were there at least 3 days a week, that someone could see them physically taking the medication. They can't give it to them. They can't make them take it, but they could at least witness that they took it so that we knew by Friday afternoon it was likely we were going to be able to give them their Vivitrol injection. So there's a lot of resources out there. What are the other elements of a shared care plan? There's a lot, but probably the most important ones are including some of the patient preferences. What do they want to be called by the team? Do they have any already known things about themselves, like maybe that they prefer to get their support in faith community versus going to NA or Al-Anon or something like that? It's not okay just to list the members of the team. It's recommended that you actually list them out, list the roles and responsibilities, treatment, shared diagnosis list, problem list, and medication list is very important for obvious reasons. Even if you are that single provider, that really doesn't have a lot of support, thinking about making sure that this information is included in part of your treatment probably will be really important in patient care. And really the documentation of that informed consent and the shared care planning discussions really lets the team know if the patient has any concerns or any reservations. Medical assessments, behavioral health systems, certainly we know those would be important, but even compliance and progress. Sometimes when I have worked in an environment where we don't have this ability to have any kind of shared care planning, sometimes you have the patient on the phone, you don't even know they missed their appointment, or sometimes, that's probably a good example. Safety plans and relapse plans, those are good to know and reinforce. Sometimes you're the person who answers the phone when the patient's in crisis, and even though it might be better for them to talk to a mental health provider or the MLADAC, you're it, and the other person's not available. So being able to access that information and then basing a plan of care from there is a really good thing. And then community supports and complementary supports. Probably don't need to get consent for all of those things, but it's good to know what the patient's doing and why they're doing it. These are just a few more considerations. And then some of the benefits of shared care planning for both the team and the patient is improved patient engagement and supporting patients' preferences in the plan of care, maximizing the expertise of the members of the team and training for each team. This is a really big plus. I think for me, we talk a lot about burnout when it comes to taking care of complex patients, and we often feel like, we aren't always well supported. Some of that's based in reality. But really looking at how can we share the burden of patient care and really, maximizing that expertise, know who's on your team and know, even if they're not stated on a list, like who you can reach out to and what they can do for support. Care planning promotes transparency and cooperation to improve relationships with both patients and care teams, improves communication and mutual trust with all team members, and reduces the impact of patient-perceived stigma. Our patients have had a lot of negative experiences working receiving care in healthcare, sometimes even in behavioral health environments, and they bring that to us. And sometimes we know them, they've been our patient maybe if you work in primary care, but really being able to sit down and talk to them about who all the members of the team are and hear all that up front really can help both you and the patient really get engaged and off sort of to a good start right from the beginning. It's not unusual for our patients to have behaviors like this, splitting staff and things like that, and really also having that conversation really lets the patient know that you value the team and all members of the team, and outlines sort of who will be working with them and in what capacities, so they understand that right from the beginning. Fosters relationships with other providers and community support, maintains a high level of confidentiality, allows team members to have access to information in a timely manner, and even shows that increases some of the effectiveness of some of the interventions, both pharmacology and in behavioral health treatment. And there's a lot of evidence about it promoting improved outcomes for patients. So I think barriers we decided we're going to hold off on, Patty, right, until we did the exercise.
Yeah, we'll make sure that our presenters get to share their barriers, and
Okay.
I'm sure. When I was building the exercise, you'll see there's barriers and successes, and I was like, we're going to have to move it through barriers, because I think we all know we can spend a lot of time talking about barriers. So yeah, we'll come back to this for sure.
Okay, and I think, bringing it back to where I started, sort of how do we use this to advance our practice? Not allowing ourselves to be overwhelmed with sort of all the things that we hear about that we can't always implement, but maybe thinking about steps that we can take in the direction. I'm sure we're going to hear from some of the organizations that they already are doing some things. And really using your experts, to share the burden of care. Start small, maybe pick, 1 or 2 team members to really focus on trying to build relationships that include more as part of the team, and utilize your technology support. Sometimes I found that it was better to email, even though it was convenient that we can communicate in the EMR, but some people get 72, patient, what do they call them? Yeah, like encounters in a mailbox, and they can't get to them in a timely manner, but they check their email once an hour, and that's a better place. So having that information is helpful. And then moving forward, if we just kind of utilize some of these principles to practice less siloed care and really take on the responsibility of what can I do to sort of incorporate some of these principles to try to provide a little less siloed and a little more patient-centered and team-focused care.
I think if you push 2 more, we have a question slide. We have the resources that Ann used for your reference,
Yeah.
and then any questions. So if you're on the phone, which you do have quite a bit, please chat your questions in, and Melissa will share them. And in the room, we can do a regular old raise of a hand. Give it a couple minutes in case anyone is typing, and what Melissa and I actually wanted to do was give our presenters a place to sit up here, so we're going to do that quickly while we bring up Dave Nashua first.
Do you want me to move this forward?
Yes.
Yeah, I have a quick question.
Yes.
Would you say that there's a particular person in the plan, or if you need to have like a certain level of buy-in from leadership, like where would you recommend? Is it organic? Does it matter? I mean, like, the person that would be the impetus that people would be most likely to say, oh, okay, I think that's a good idea, or?
I mean, I would always recommend, like, if you can get buy-in from administration, that's a great thing. But I think it's the boots on the ground people that this really benefits, and I think some of my experience being even in new programs is we made that decision as a team. Like, we got a we gotta figure out a way that we can share this information in a more timely manner or, a less restrictive way, you know, and some of that came through transition. I mean, this in particular, the information that I found was, often connected to, like, patient-centered care in, home care, elderly care, and pediatric care. So I only found a little bit of research, honestly, where it was connected sort of to substance use disorders and addiction care, but it makes so much sense, you know. I think we do a lot of duplicating things, too. When I don't know what the MLADAC plan is for the patient or what they made for a plan when they left, then I see the patient another time and have no idea about what that is, or pick up the phone and talk to a patient and don't even know what the plan is. You hear it from the patient's voice, and I don't mean to insinuate they're not telling the truth, but they only know their perception of what happened. And it isn't always in line sort of with my perception as a team member.
Yeah.
You know, so the more that we can work in that direction, I think it really helps that too, because we are all working hard, you know, and it is very blurry. These boundaries are very blurry, you know. So, did that answer your question?
Yeah.
Okay.
And we did have a question, from our online participants. So Polly Morris, is wondered if the recovery supports are integrated into these teams in shared care plan, and if peer recovery support services develop a wellness plan. Sorry, I'm reading it like a question, but it's not. Peer recovery support services develop a wellness plan with persons receiving coaching as well as other offer ongoing support. So basically, do these shared care plans include recovery support?
I mean, I would hope that they do. It was on my list. I think some healthcare organizations are starting to implement recovery care workers, and I know some teams have them as part of their team. So I would think when they're internal anyway, or integrated into your team, that would probably be more likely. You know, they've even working with like the Doorway in Manchester. Wasn't always, you know, we were still kind of developing those pathways of communication, but a consent would allow us to talk to a recovery support worker, and for some people that might be really important. That might be the one person that they're connected to in the community on a regular basis that really may be able to, you know, provide that support and reinforcement of the patient's plan. So I think it's something you have to consider on an individual basis. I mean, the other thing to consider is the whole idea of confidentiality. You don't want to just get 25 consents when you're sitting down with a patient, because you might need to talk to this one or that one. But if the patient identifies those, you know, my recovery coach is a really big part of what my supports are, then I would think that the team would probably want to include that person as much as they could. Some of the, I don't know if naturally you guys have a recovery support worker. As part of the program, but I don't know about weeks either, but I do know that some of the programs that have people that come here regularly do, so.
Any other questions for Anne before we move to our Nashua friends? Great. So I set up these chairs for you very nondescriptly. You didn't even notice I did it, I bet. And so everyone in their handout has the case that the folks in Nashua prepared for us. So what we're going to do is really kind of look at this through the lens of a particular patient. So what they're going to do is walk us through a patient that they've identified and kind of give you the background on what this woman is working on and struggling with and what her goals are, and then kind of talk about their approach to treatment with her and how they've incorporated shared care planning into their treatment team and how they kind of do through the lens of this particular person. Take it away.
Do we have is there a slide for the?
No, they all have it in front of them, so it's just this.
So a little bit with this presentation, I think is kind of how we survive in the clinic. We're newly open in the last few months and have kind of rotating providers. We don't really have an anchor provider. So my role with this patient, who's a 41-year-old woman that has both opiate and alcohol use disorder, was kind of stepping in when she missed her appointment with the morning provider. She was someone who was transitioning from methadone to Suboxone, and the reason for that was she's got a young child at home, was struggling with her social situation, couldn't make it to the methadone clinic, and on the day that she couldn't make it to clinic, she would drink to manage her symptoms. So she came with a plan. The first time that I saw her, she had done a home induction of Suboxone, and then was in for the brief, follow-up appointment that we squeezed in. She has a lot of social challenges. I think she's currently living with her mom. There's 4 children. The youngest is almost 2, and then the older ones are, I think, 10, 11, and 18, or that ballpark. How we work things a little bit in the clinic, I think, Kristen, you're often the first person that sees the patient to do the intake. Kristen is our MLADAC, and Anne Marie is our everything else. Wears multiple hats. We do have someone that answers the phone up front, but they don't really have much background and can't be someone that can really triage or help. It's more a message kind of giver. So I don't know, in terms of filling out the social situation, if you guys have any more details about that.
Yeah, at that time, she was gonna have to move out of her apartment. She hadn't paid her rent, so she moved in with Mom, who has New Hampshire housing voucher, so she's really only allowed there for a month, so she's already, I think she's at the end of the month right now, so she's still really struggling with what she's gonna do in terms of that. The mom and she do not get along. She describes her mother as very toxic and nasty, amongst other more colorful words, but has to rely on her. She also had cared for the two older children, and this person had her youngest with her.
And the other main area which I think a lot of our patients have is the mental health challenges, and she struggles a lot with depression and anxiety, and that absolutely figured into trying to manage her medications and augmenting her, to try and have a more robust treatment plan for her, I think. And then we ended up having a lot of challenges with accessing mental health services, and also having different providers seeing her on different visits, each of which had different ideas or comfort levels with what they would be willing to do, and also the patient having a lot of restrictions about what she would or wouldn't do and what would work for her or not work for her.
Transportation is huge for her too. She can use Mom's car, I think, occasionally, but isn't always allowed. If she puts gas in it. We have given her cab vouchers, so we can ensure that she's getting to and from the appointment.
She does have access to CTS, but her depression and her anxiety is so intense that she cannot, most of the time, make those appointments. We did have a success yesterday. She made a CTS appointment and actually came to her appointment yesterday. But she's very paralyzed by her anxiety. She was taking a large amount of Klonopin, which was prescribed by her PCP. She currently cannot get a refill on that, so she's no longer taking it. She was taking up to 4 milligrams a day to manage the anxiety, and so when Loretta...
She was overusing the prescription.
She was, absolutely.
Yeah,
no.
She was that day, and
she was overusing
and
it.
just to kind of put the PCP hat on, I think they were someone that was fairly new to her, and she was trying to temporize and manage things for her while she sent her for us and made the referral to behavioral health. So it was, she was trying not to drink, using more Klonopin than she was supposed to use, and just kind of multiple challenges.
So our care plan is in the EMR, which any of you who use care plans in the EMR know that that's not really very efficient. We don't have a specific care plan dedicated to planning care for our MAP patients. So it is in multiple places. So you'll find it in the providers area, you'll find it in Kristen's area, you will find some of the information in the documentation that I do as a care coordinator, but there's no centralized place for it. And I know that Kristen and I have talked. Do we need to take all of this and make a paper care plan? Do we need to have this in a centralized location? But the good news is that we're getting a new EMR system in November, and it will have a care plan there that we can utilize, so everything will be accessible by all the providers.
May I ask what, just on that?
Epic. Yep. We've been promised it's there. If anybody knows differently, please speak now.
They build each system separately.
Right.
Yeah. Yeah.
We haven't had that inquiry yet, how would we like it to look?
Yeah, make sure you.
And there's also been kind of resistance. Actually, when we started the program, we work in Centricity now, so we did get some support to build a MAT visit in there that we kind of borrowed from other programs. We were lucky to have that, at least to have some structure that we could be able to pull some data and have things kind of look the same when people are going through. Although there is a lot of variability with how the different providers use that record, whether they use the pull downs and documents so that things carry over and whatnot. So I think the care plan is these two and the provider of the day.
Yep. Exactly.
And we are right next door. Yeah,
Yeah,
we've
they're
got
all,
one,
it's
everybody.
all in a little corner, and we're very small still because we don't have the provider bandwidth. So I think as that increases, we're projected to have that more full-time help coming in the next few months. So kind of that transition, I think, is going to necessitate, as we get busier, will make it a little more challenging because you guys know everybody very intimately and are kind of teaching the providers that come in and out and making suggestions, and we all kind of collaborate and put our heads together. They also, I'm in the building, so I come in and out of the program as needed, but I can get a text or a call, and what do you think, or what should we do, and pop by. So it's kind of, it happens regularly, but it's on the fly, and it gets documented in both places, in the behavioral health piece and the...
So the good thing is about being small right now is, as Dr. O'Shea said, we collaborate all the time. So Kristen will see a patient prior to the provider. She'll come into the office with the provider and she'll give us a quick overview, and the provider then has additional information. After I've done the admission assessment, which is sometimes on the phone, sometimes in person, I will share that information as well. And when I first speak with a patient, I talk about a shared care plan. I talk about our team. I talk about how this is our team, these are the people you're going to be seeing. We want to talk with you, we want to find out what you want, and we want to come up with a plan to get you where you tell us you want to go. And so the really nice thing is that every single one of us, when we're interacting with the patient, is on the same page. And that's been really, really helpful, especially having multiple providers in and out. That's been extremely helpful. And even those providers who come in, we have one provider who comes once a month. He comes in, he wants to know where the patient's at. Most of the providers prep. They'll look at the notes in Centricity the night before. They'll come in, they'll have an idea where the patient is at. But in terms of the care planning piece, we're just all doing it all of the time. With this patient in particular, her successes in terms of our care planning is that she's successfully moved from methadone to Suboxone. Even though she had some additional use, she had opioid use, she had a lot of alcohol use in the beginning. But she did that transfer successfully, and it improved the quality of her life. And she's very verbal about that piece. She's verbal about how the Suboxone feels in relation to how the methadone felt and how much better she feels. She also comes, she keeps coming, even though sometimes she doesn't come to her scheduled appointments. She keeps coming, she keeps answering the phone, she keeps calling us back. And, she has not been using the benzo because she's not had a prescription for it. And she came in the time before last and said she had not had alcohol for 3 weeks, which was later confirmed by a send-out urine. And she came in yesterday, she called CTS, she came to her appointment, and even though she had run out of Suboxone because she missed appointment in between, she still had not used substances and she did not drink. She's not engaging a lot in therapy. She's really pushing that away, not showing up for appointments. She did in fact cancel the the BH provider appointment that we had gotten, and now she's been pushed out to the end of March. Fortunately, yesterday, our provider did start her on some Zoloft, which she was pretty resistant to. She's been resistant to most of the medications that we've suggested, like clonidine doesn't work for the anxiety, and hydroxyzine doesn't work, and nothing works.
Alcohol doesn't work, and
Right.
sleeping, anxious.
Yeah. But as a team, we all spoke to her, because initially it was, no, I'm taking nothing, and to, well, maybe I'd take it, but I have to do some research, to, okay, I'll try it. So by the time she left, she did have a prescription for that, with sort of thinking about the fact that she'll have 5 weeks that she'll be on this medication. She'll have some idea if it's working. It may be something that they can rule out. It'll be one med that the med provider doesn't have to try if it's not working at all. So that was really yeah, lovely.
Oh, we found him.
So again, the most challenging piece for us right now is not having a consistent provider. That will change come June. June seems like a long way off to me, but but it's happening. It's a light. Yes.
It sounds like within your practice, it's very great communication. What do you do if a person has like a mental health provider that's outside of you guys, or, someone that you need to work closely with that's prescribing for them maybe, that's not embedded so well like you guys are?
So we have releases of information. The behavioral piece Kristen takes care of. She communicates with the therapist, with anyone who's providing care on the outside. Many of our patients come from primary care, so they are referred to us. Our consent covers our primary care practices, so we have good engagement with the primary care physicians and nurse practitioners. We can send them a note, we can flag them in a flag, we can flag them in a note. So I think that piece has been pretty good.
Or we help with referrals to
Yep.
outpatient behavioral health.
We're fortunate too, because we have an in-house IOP and an in-house PHP.
In communicating like with the hospital, if somebody who was in the recovery management clinic but has to go in the hospital either for, hospitalization or is seen in the ER, can they access the information
If they
about
choose
your
to.
program, the providers can?
They can if
Yeah.
they look.
Okay.
It's scary.
So, I'm just curious, so what kind of model care is this? Is this
It's not a clinic, it's actually a practice
practice?
setting, not a primary care practice, but a practice setting.
And who is it under?
So right now, we have multiple providers, both
So is
physicians.
it a private practice?
No, it's part of Foundation Medical.
Foundation Medical Partners.
Okay, and they're part of
Southern New Hampshire.
Health.
Yeah.
Southern New Hampshire Health.
New Hampshire Health?
Southern New
Hampshire
Hampshire Health.
Health.
Southern New Hampshire Medical Center.
So instead of integrating into primary care, is it sort of like a spin-off?
So we, go ahead.
No, go ahead.
The intent is for us to start them, get them, stabilized, and then send them back out to primary if they're willing to.
I think it's part of a way to engage primary care providers where there was a lot of, not resistance, but hesitancy, you know, like, how do I do this? People feeling overwhelmed with doing their documentation for people that are not as challenging necessarily, or challenging in other ways that they felt more comfortable with. So part of it is some of the folks that work in the clinic are primary care doctors, so they're coming on their off day, doing a half day, and bringing it back to their practices and trying to spread the word. I think when we initially opened the practice, the thought was that we would have like a lot of, maybe 100 people did the training, and maybe 10 or 12 got waived, and the thought was we'll have all these people come in and take it back, but the reality was not that many people, and we're still trying to encourage people. We actually have some people that are shadowing us now. We're doing little, what we call our road shows, where we're going to like the primary care practice division meeting, the family practice division meeting, immediate care, talking about what we do, encouraging people, and we've had people coming to shadow the clinic and the providers that are expressing interest in coming to work. So I think it's working in a slow way, but we also recognized we're not going to have the bandwidth with that model pulling people in for a half day here and there, and also the challenges of if you're here once a month, that patient needs to be seen more often. It's much easier to engage a patient when there's have continuity with the care, you know, with the provider being an important part of the team. So thus the full-time person, but there's still room to have people come in and work their half day once or twice a month, and get more people involved in that way.
We take referrals from our IOP program, our behavioral health unit, partial hospitalization program, eventually be opening up to our emergency room, and the main campus, and.
Yeah, if people call, we don't turn them away.
We don't say no to anyone.
But we're not advertising, because we don't, yet, because we don't have
You don't have
a
enough
provider, we don't have.
providers. Yeah.
Great, thank you. Very appreciative of the trying to, create that more access in primary care and the challenges with that. I work with Concord Hospital, so with medical practices, so I completely understand.
And we've heard too that some of the providers that were doing it, but didn't have the support of the MLADAC or the care coordinator to kind of focus that in real time, made it challenging. So I think it's been a great model.
And the primary care providers that are coming, they're our best advertisement, because they love coming, and they've learned a lot, and they're willing to learn, and they're open, and they realize that these people are just people, they're just patients, nothing bad is going to happen. Just lots of good things, and so they're our best, they're absolutely our best advertisement, because they're going back and saying to other providers, hey, you know? Yes.
I have a question about, have you successfully transferred someone from your program to a primary care physician, and are they just seeing them as part of their regular daily schedule, or are they separating time aside for kind of their own mini clinic? How is that?
We have transferred 3 people back to primary care, and they're seeing them in their regular slots that they would normally see them.
And they're doing the drug screening?
They're doing, they're following up on the pieces that they need to follow up on. We had one patient come back to a Manchester primary care provider, and then 2 into our own. The 2 that are into our own, one is a naltrexone patient, PO, and the other is Vivitrol. So they are probably the most simple patients to manage.
And they're getting the Vivitrol in the primary care
Mhm.
office.
Do you stay with them, Anne Marie, as a care coordinator, or just as?
No, I do not. Not until some of my hats are gone, please.
I do stay with them.
But that
Yeah.
being said too,
Yeah.
I mean, there's that continuity, and people would always call if they had a question.
Exactly.
Or they could come back if somehow something wasn't working. People
Yeah, the care coordinators from the practices do call me, you know, asking for information, and, we get a lot of referrals that way. The care coordinator is the person who, you know, the physician goes to and says, okay, we need something here. So we do that a lot. Yeah.
It sounds like a lot of the challenges for this woman are really around the social determinants of health, you know, transportation, childcare, housing. So, do you have any resources within the health system as far as like social workers that could work with her on looking at housing, or how does?
She's working on that, all of that. I do function in lots of social worker roles. Anne Marie does some of that too. But she's waiting for the bridge grant to come through for her. So that stuff's in the process.
Okay.
Depending on what they're eligible for, sometimes we refer them to Community Mental Health Center for case management, or Harper Homes has some case management stuff, for housing. So there's some referrals. Like, I would never go out into the community and follow them there, but certainly provide the resources.
I'm wondering about in Nashua, I don't know if it's still around or not, but Marguerite's Place or Pastoral Care, and I think they have the Cynthia Day program there. I don't know if she's looked at, but they have more case management, and Families in Transition is in the Manchester area, but more case management and support. And I know Marguerite's and Pastoral Care used to have daycare on site too. I don't know if you know about those, but.
Yeah, Margaret is waiting.
Yeah,
All these programs are waiting.
Yeah.
She originally considered, Families in Transition, but she didn't want to leave Nashua.
Because
Yeah.
two of their children are with her.
Here. Yeah.
So Marguerite's and Pastoral Care are good for, even if there is a waiting list, that might be something to think about.
Yep, absolutely, thank you, good suggestion.
Are there any other challenges, related to your care planning for this patient or other patients that you feel like you want to talk through with the group, or any more questions from people?
Do you guys find it hard to coordinate care with external agencies? As far as getting people to get back to you, or being able to connect with the right person and the various locations?
Sometimes.
It takes a little while for people to return phone calls and just
The good piece right now is that we don't have that many patients, and so I have the time to make 30 calls in a week.
That's what I worry about, Anne Marie.
I know.
Right.
It works very well when you have,
Yep, that's no.
What's our patient count right now? Is it 45?
45 active, but 51 that have gotten services.
Since August when we started. So that's, I feel like you spend hours, and we're learning more, so the prior auths for a higher dose of Suboxone, or the Vivitrol has to be 3 weeks, or the patient's shown up and they've been getting the dose at the pharmacy and now it won't come through, and you spend hours on the phone. So I don't know what we're gonna do. I mean, hopefully we're getting smarter in terms of anticipating those things.
We're gonna have more staff, we're gonna be good. We're all gonna be good, we're gonna have more staff.
Feel your pain.
Yes, yes.
Well, and I think it's great that you're referring back to the CCP, because in my perfect world, we wouldn't have clinics. We would just go to the doctor and get treated for an illness. And so, and I don't know of any other program, I don't know if anybody else does, that has that, where they're referring back, and PCPs are taking back their patients that are stabilized and trusting that they can send them back to you if they get nervous or have an issue. So I'd love to hear, as your program grows, how that's working for you, because I think it'll be great to say, hey, look, this program's doing this and it's successful.
And that's our goal, and those are, those are the things that we're looking at and we'll be tracking for sure.
Yeah.
Nice to have you back.
Oh,
It's
dear.
interesting, you mentioned that two of the patients that have transitioned were naltrexone or Vivitrol patients, and that they are easier, and I think in my little experience with this, I don't understand why, but, I think we all know people seem to do so well with alcohol use disorder and Vivitrol, and, it's just less case management, less, overall, it seems like it's just an easier transition, and what it for, as a provider, I think it gives you a sense of empowerment that you can actually have something that really, really helps people too, and it's not such a hard step. So there's some of our people that are working in the clinic have said they're approaching their own primary care patients differently in terms of doing a deeper dive into the alcohol history, because they feel like they have something that they can offer. So it's almost like a door opening in terms of people having more open-mindedness about substance use disorders in general, I think, and making that more palatable, or so hoping to get our primary care practices where they could all do the Vivitrol. Right now, there's only certain sites because the nurses aren't trained, and there's been a lot of resistance to doing that. So even if the provider's willing, if there's not a nurse in practice that is willing or has gone through the training, so they have to have buy-in kind of from everybody, which has been a little bit of a...
And getting prior auths and getting that stuff done for some of the patients for Vivitrol is a lot of work, and they're already, their panels are already full to the brim, and so it really is difficult to expect them to be able to do that at the drop of a hat. And that's going to be education, that's going to be the traveling roadshow stuff, so that people know, they're educated, and they understand that it's really pretty simple once you know the steps. And it makes such a difference in a patient's life. So we'll get there.
Any other questions for Nashua?
I have one if we have time. Do providers that do primary care screen for alcohol and other substance use disorders now as part of sort of their normal?
They do, but it's part of the checklist of everything else that you're figuring out, and maybe I think some do it differently. Some have a clipboard that patients do while they're in the waiting room, or some have their MA go through it, which, I don't know. I know when I've been asked about how many sexual partners I had by the MA when I'm at my GYN appointment, I'm not happy to have that, like, I don't want to talk to you about, like, so I think that I don't think people get good information that way. So some of the screening tools, and there's just, you have to check it off in your EMR, click the box. So I don't know that there's good self-reporting, and I think people get busy and they don't necessarily dive in if the red flag isn't being raised. Unless they've had, their LFTs are out of whack, or there's a complication related to that brings it to their attention. I think they're easy things to click the box and not have a conversation about.
And I think sometimes also you'll see that, that there is discussion in the notes about a substance use disorder. But the primary care don't really know what to do about that. And so they say, stop drinking, stop taking drugs, go get some help. And so this makes it easier for them, because they can say, oh, well, there's this program, and, we'll get you hooked up with it, or here's the number. But it's, you do see a lot of that. I see a lot of that when I review charts. I see a lot where people have consistently come in, had issues with substance use. There's not even a diagnosis in their problem list that says, alcohol use disorder, substance use disorder. It's not even there. Or
we'll say opiate use in remission.
In remission,
yeah. It's been a long time.
You'll read the note, it'll say, patient hasn't used opioids in 3 years. They're our next patient we're seeing.
Thank you very much.
Thank you.
Now we'll bring forward Jennifer from WEEP. So her case also in your handout, second one.
So this is kind of lonely up here. I don't know my team. Although that's not fair, because, and I am absolutely going to point you both out, So Shauna Delworth is a therapist in MLDAC that I work with in another portion of the program, as is Lydia. She's a psych MP. So we all work together at Weeks in different parts of the program. And that's probably some of the challenges that I'm going to talk a little bit about today, because Weeks has sort of a unique situation that way, and I'm curious to hear if there are other organizations who have some similar things going on. Because not only, you know, are we sometimes challenged about having, you know, a kind of satellite practice that is both medical and substance use, but we're also challenged because each portion of the program is a little bit different, and it's also in a different geographic location. So there's some stuff there. We'll unpack that. So the case presentation that I'm doing today is she's a 31-year-old woman being treated by the NCRC, so the North Country Recovery Center, which is the program through Weeks, you know, specifically for substance use disorders, primarily for opioid use disorder, but also for stimulant use disorder. She also has, you know, as it's mentioned, some mental health diagnoses, especially post-traumatic stress disorder, major depressive disorder, and also generalized anxiety disorder. I apologize, I did not include that there, but you can probably expect that given all of the rest of her diagnoses. So she is currently, as you know, if you took a look through her ASAM, she is a patient of high concern. You know, she often, you know, currently she is receiving Suboxone to help treat her opioid use disorder. She's participating in individual therapy with me, both mental health and substance use treatment, also group, regularly coming to group therapy, and also engaging in case management. And we have a case manager there as well. But she's having great difficulty with stabilizing, you know, both stabilizing in terms of you know, being able to go forward to reducing her substance use, but also in achieving some of her goals, which, you know, I mentioned on the first page, you know, to be able to stop completely from using illicit substances, except for marijuana, to have employment, housing, and also to continue to explore her spirituality and how it can assist her in her recovery. So, you know, at this time, you know, and actually, you know, I saw this patient this morning, so really, you know, it's pretty fresh. So, you know, over the course of months that we treated her, there have been several periods of time where the recommendation has been that we help her find a higher level of care, whether that be PHP or inpatient, to help her stabilize, and that's not something that she has responded to at all. We've also recommended IOP. As recently as a little bit earlier this week, she sat down with her, her psych NP, who also is prescribing, is also her MAT prescriber too at this time. And the three of us talked all together about what's our next step, because clearly while her substance use has reduced, you know, so harm reduction is achieved in that way, she is still continuing on at least a weekly basis to use fentanyl or methamphetamines, depending. So, you know, her highly emotionally dysregulated. So the three of us all sat down together in a room together to come up with a plan. And fortunately, through one of our other one of the other branches of our programs, we have IOP starting up, so it made a referral to them very easy. So she's going to be starting IOP on Monday, and we're going to be able to assist with the transportation in that way, through the doorway. And also she has access to CTS. She's continuing to, as she is able to, you know, we're going to monitor and communicate in that way, continue to come to group if she is able to, and also continue with individual therapy with me, and meeting with her psychiatric nurse practitioner to help with behavioral health medication, so to also help her mental health concerns, her symptoms reduce, so that she can feel more stable in that way. So she is going, you know, up a level of care, and she is willing to participate in this at the moment, and we'll see. We'll see. So, let's see, I'm trying to think what else would be good to give you a snapshot with her. As I mentioned, we clearly have a number of members on the team just within our program. This actually might be a good time to kind of talk a little bit about the structure of Weeks. So Weeks Medical Center is a hospital and primary care organization. So really the program, the NCRC program, is through primary care, and that's where it originated, was to have a program where there were certain hours where there were MAT providers to be able to prescribe Suboxone, Vivitrol, Sublocade, naloxone, and, various and sundry others, but to be up on addiction medication. And as part of that program, and this started approximately 3 years ago, Weeks also recognized the importance of behavioral health counseling, or certainly substance use counseling, as an integral part of that. And so that was the birth of the program. And so those programs are in our Lancaster location through the primary care there, and at our Whitefield location, which is the next town over, if you don't know the geography of the North Country. Because one of the problems, or one of the challenges that we are challenged by constantly, is how rural we are, how far apart everything is, and also that we have these centers of individuals who are struggling, but that they're very far apart from each other, and lack of transportation, public and otherwise. So we have various locations to try to meet patient need. So that has come about, and there were specific medical providers who got waivered and were able to provide MAT, and Shauna was the first therapist to start treating that way, and that's when I came on board. Since then, however, that was our program for approximately 2 years, right, Shauna? About 2 years. So at the beginning of last year, of course, everybody knows about the doorways. The doorways opened, and the way the state distributed the funding, it was for geographically central locations in the different counties. So the funding and for the grant went to Littleton Regional Healthcare and also to Androscoggin Valley Hospital. So Littleton and Berlin, because they were central to their counties, but did not have an operational substance use program of any kind. But Weeks, which is in the center, did. And so at that time, both hospitals contracted with Weeks to provide those services. So at that time, and I apologize for giving everybody a history lesson, but I think this might give you a picture of some of the complexities that we're dealing with here. So at that time, we staffed both doorway programs and decided at the time that we were already doing medication-assisted treatment, so it made sense to have both hub and spoke in the same location. So you have, the case management and assessment and connection services of the doorway, and also a MAT program wrapped into one. And so we did that both in Berlin and in Littleton. Fairly recently, within the last 2 months, the doorway in Berlin, which is where Lydia works, is up and running, doing their thing. Things are great. However, Littleton and Weeks has decided to part ways, and so Weeks has a branch of the NCRC in Littleton, providing medication-assisted treatment, or medication-assisted recovery, and it is a third location with a third program model, because
North Country Health Consortium?
I'm sorry?
NCHC, North Country Health Consortium?
No, we work very closely with them, but we're actually one floor below them in the same building, which is kind of awesome, but it's the North Country Recovery Center, NCRC.
Okay, thank you.
Yeah, no problem. So that program takes walk-ins, we see a lot of people who are in crisis, and we're operating on a similar model of the one that we created at the doorway in Littleton, but we're not the doorway. So as you can imagine, there's that model, there's the model of the doorway in Berlin, and then there's the model of the original NCRC that is embedded into the primary care services and receives referrals specifically from primary care. So in terms of of coordinated treatment planning. It can be very challenging because each program has its own, you know, we try to make it as uniform as possible, but it's impossible to do so. The patients who tend to come from their primary care doctors tend to be more stable. You know, they're already going to primary care. They have that established. Oftentimes, they're pretty functional. So they're relatively stable and also tend to be more engaged in therapy, in group, those kinds of things. The patients who come into the doorway and who come into Littleton, they can be walk-in and tend to be much more sporadic with their participation, and much more just, you know, unstable with their living environment. And this young woman is, you know, I work in the NCRC, the separate program, the one in Littleton, so that's where I am seeing her, and where we're working with her. So, bit of a mouthful, but, so in terms of organizations, that's a big challenge that we have for shared treatment planning. Because in the North Country, patients absolutely flow from one program to another. Starting in Berlin, they lose housing, they come to Littleton. They'll lose housing in Littleton, they go to Groveton. And so there's a fluidity that needs to happen there because the patient population is very unstable, and also there are very few resources in the North Country. So we kind of end up having to do a little bit of everything to get to everybody. So with how we accomplish that, and I'll say, you know, how we are able to kind of do that and maintain it, and then also, you know, we do have some significant challenges, as you can imagine. We talk a lot. That's kind of the beginning and the end of it. So we use, you know, email, we use an instant messenger, we use a messenger that's embedded into the EMR. You know, so there's a lot of conversation coming back and forth. We read each other's notes. And then when we're in the same location, we actually talk face-to-face, which actually, believe it or not, happens more frequently than you think, because with these programs, it tends to be the same providers in each program, and it's pretty steady. So I'm in Littleton, and there are two medical providers there, Dr. Nielsen and Jen Parent, who's a psych nurse practitioner, and then, you know, a case manager, but there's a floating case manager. So that's sort of and a team leader and a few other people as well. But that's our program there. And then in the physician embedded, or the primary care embedded program, you know, there's Shauna, there's an additional medical provider. I also do some counseling there too, but I move around a little bit. And then Berlin has its own team too. So we are actually able to be in the same place at the same time. So there's a lot of conversation. And we also, for our program, and this is something that we are constantly adapting, our program expectations. Because while obviously having, you know, care planning that is where the patient is at, we're meeting them where they're at, and they are very much involved in what's going on with their treatment. Also, as a model of philosophy, there are certain expectations that we do have of patients who are coming into the program, namely that they are engaged in some sort of counseling. And that's a tough sell. I mean, why wouldn't you want to come see me? Come on, I'm great, right? But there's a lot of people who don't. And so it's something that we're challenged by. And of course, that happens more in the doorway and the satellite practices. But it's an expectation that we have. And so that tends to be, so coordinating that. One, that's an expectation that's out there. So that's sort of built into a lot of treatment plans, that people know when they come to the program that is an expectation that we have. And it's available on-site, but also if they choose to have an off-site provider, that's okay, we'll work with them there. And then what form that takes, we're obviously much more flexible depending on where somebody's at in their recovery, you know, and we talk a lot about what their expectations of that kind of treatment are. That tends to, you know, fall on me or the therapist. Those are conversations that we have. And then medical providers have other conversations in regards to, you know, what's the appropriate level of medication, that kind of thing. And then we all talk. In addition to the conversations that I mentioned that we have. We also have what's called an interdisciplinary team meeting where we all sit around a table and we talk about patients and who are we concerned about, where are people at, you know, what's coming up for them, so that we all can be on the same page. So one of the challenges that we have that I think that we all, and I actually was hearing a little bit from the Nashua group too, that this is a similar problem for you guys, is our EMR. So in terms of having a unified living document care plan, we don't have one. And that's challenging, and that's something that we've all recognized as challenging because, you know, while this form of communication is great, it's also challenging to sustain. And also, you know, I mean, it's good to have something to just draw off of and change and to document what our direction is. That ability not existing in the EMR has been really challenging for us to create one that everyone can access and update. And we have ECW. I don't know if anybody else has that, but you know, we haven't figured out how to make that work. We also are changing to a new EMR as of, I think, October, and so far I'm not sure whether that's going to meet our needs or not. I think also, and I would be really open to hearing from other people about their thoughts on this. Something that I find, and I think that some other people find challenging, is we're really very much meshing a medical world and a behavioral health world. And that's a big challenge. We think about patients very differently, and our expectations for how we do case planning are very different. You know, coming from a community mental health background, you know, your treatment plan is the thing, and you update it every 3 months, and you know, you go over it, and it's, I mean, so, and that's what everything is based off of, and everybody looks at it, right? But with some of our medical providers, that's really not the world that they come from. And so integrating that together is a challenge, you know, and while everybody recognizes the importance of talking to one another, that the idea of having that document there, I think, has a varying importance depending on whose discipline, you know, what your discipline is. So it's something that you know, I mean, that I think the presentation earlier, culture clash, was up there, and that's something you know, that we work through. You know, we all respect each other where each other comes from, but it's a very real thing. I'm trying to remember if there's any other successes or challenges. Okay. So for this particular patient, although you know, in terms of treatment planning, and I apologize for being a little all over the place, wanting to cover everything. You know, I've mentioned some of her challenges, that instability is something that's very challenging for her. But I think, and this will actually go into something of an organizational challenge too, that her substance use is reduced. You know, she is not using daily. She's not using either meth or opioids on a daily basis. And so that's a success rate there. Additionally, while her housing has not been hugely stable, she's not living in a car this winter, which she was last winter. So there's some incremental changes. You know, she is willing to engage in therapy. She is willing to engage in IOP. And so I think that those are all successes that we need to count. And that's actually another challenge. And I'm guessing that a lot of people also face this challenge, is what constitutes success. Sometimes, you know, when we often will talk about our programs in a medical setting, we have medical provider meetings where everybody from the hospital, all the primary care get together and we're talking about things. Or we'll have an M&M where we're talking about case presentations, right? We encountered this about a month ago where one of the providers was saying, not involved in the MAT program, was saying, oh, so how many people have gotten off Suboxone? Meaning, what are your success rates? And so I am seeing lots of nods, right? And so we had to explain that, okay, that is a success, but that's not the only success, and that's definitely not the only thing that we need to count as a success. And talked a little bit about how, you know, even a reduction in use is a success, you know, that there are many, many different markers of success. So again, culture clash. And fortunately, everyone, at least to what I thought, was pretty open to that idea, but reminding people that success looks very different, and honestly looks very different from what a medical success rate might look. And for all the medical providers in the audience, please correct me if I'm wrong. But, success, at least to my understanding that way, is when you cure the disease, right? It's when a person gets a treatment and they are, a remission of symptoms. And that's not the world that we live in, at least in terms of substance use, it's the reduction of that. And so sometimes that tends to be challenging, not for those who are working in the medical world to grab a hold of. So communication, out of the program can be challenging in that way. So I think that's about all that I have, unless there's something else that people want to know about.
Jennifer, I wanted to let you know that when you were sharing your successes, Polly online shared hooray and woot woot, and she said, recovery is wellness and leaps and bounds, or in small increments. Success is celebrating life in whatever way works best for them.
Awesome.
Giving you some big kudos there.
Marvelous, thank you.
So questions or responses, Jennifer identified a couple of things that she is interested to hear all's perspectives on.
Is your IOP abstinence-based?
It is not. It is, at least to my knowledge. So it's something, so I've had less to do with that particular part of the program because it's the one that's located in Berlin. I don't believe it's abstinence-based. I believe it's harm reduction. Is that right, Lydia? Okay.
And you said that a part of your program is that counseling is an expectation.
Yes.
If that expectation is not met.
I knew someone was going to ask me this question.
Well, I mean, yeah.
Of course, it's just low-hanging fruit, right? We don't kick people out.
Okay.
I mean, so if it gets to, I'll actually go back to Dr. Milai, his presentation that was like a year ago, and that is that if things get to the point where somebody's doing time and they're not doing treatment, we do
Provide them
we do
other
consider that.
opportunities.
Yeah, well, we provide opportunities, honestly, so in probably I don't even know the number off the top of my head, maybe 300 patients over the last few years that we've treated. I think there's probably 5 or 6 that have been discharged. And generally, those are for things like, those are extremes. Often what we do is if somebody isn't participating, really, one of the concepts that we're working with is if somebody's screens are clean and they're coming to their medication appointments, but they're not participating in therapy, is do we shake that tree? On somebody who's being successful and, therapy might not be part of their success. So those are things that we're revisiting. However, if a person is coming up with positive screens and they're not participating in therapy and in that piece, that is something that we talk about pretty frequently. And the idea is okay, how do we wrap around you? How do we increase the services? Now, it's a challenge, of course, because, person already isn't coming. So how do we do that? So it's something that we struggle with a lot. And I don't pretend to have the answer.
Can I add in?
Of course.
And the program that I work in and that Jen is in, the NCRC program, therapy is connected to the provider. So if they're not coming to see me, I'm reaching out to Lydia as a provider and saying, you're seeing so-and-so on Thursday, I haven't seen them in 3 weeks, can you get them to schedule an appointment? And so she'll say, okay, I'm going to give you a script until your next therapy appointment. When you go to therapy, have Shauna IM me and let me know that you showed, and I'll call your script in pharmacy. So we kind of ping off of each other, and that really helps kind of keep the consistency. Part of the problem is therapies, we're backed up, so if you miss an appointment, and patients are smart enough, they figure it out. I missed my appointment this week, I won't have to go for 3 more weeks, and then I can figure out how to miss that one. So it's, trying to help kind of reel them in and get them in.
Absolutely.
Yeah, two things. Looking at the social determinants of health and transportation being issues. So are you using telehealth at all? We provide through telehealth, and that could wrap around a lot of the services that you have and relieve some of the backlog in getting to therapy for organizations that already have MAT, so that's one. The other thing is in your success stories, do you wrap around HEDIS measures? And do you use the HEDIS measures? I assume if you're connected to the hospital, a lot of those HEDIS measures would show success. So
Yeah.
less rehospitalizations, getting connected to treatment, 14 days, having
Oh, that's okay.
visits afterwards, because those are actually
Yeah.
process measures that actually do these.
They are, and that's a really good point, and we do keep track of all of those numbers. I think in terms of presentations, that's something that's probably good to pull out when we're making presentations, to look at that. And I think too that, the providers that we work with are highly sensitized right now to the social determinants of health. We've incorporated a lot of that in primary care, the primary care interview as they're coming in. So it's a really good idea to draw off of that, because we've been having some conversations recently about, how are we reflecting these numbers. So, thank you.
And what about on the telehealth?
Telehealth, we have not yet, although I know that Lydia went to a presentation about utilizing telehealth, and so, I think that's definitely up for conversation. And it's,
It's just, right now, yeah, it's just kind of stalled until it does meet.
Okay.
Yeah.
Great, thanks.
No problem.
How long is the wait for a patient to start at your program?
There is none.
Okay, so if somebody came from a hospital seeking that, they not need a bridge clinic?
Well, it is, maybe a few days. The idea is that we try to get them in as quickly as possible, and if they need a bridge, there are different opportunities for them to be able to do that. Certainly and I think it's probably different in Berlin, where I know that we have done some bridges. I don't know how frequently we're doing them over there at this point.
I'm there most days, so they just walk in, that's, within business hours. After hours, we have a little trouble with the ER helping us out, so they're kind of on their own at night and on weekends, so.
Yeah. And I know in Littleton, typically there are providers there 3 days a week. On the days that they're not there, we can utilize the doorway. We also have great difficulty with the ER in town. So often somebody comes in and, one of the providers who are available remotely will assist with some kind of bridge until they can come in and see a provider as soon as possible. So, it's usually just a few days. But this is another challenge that we have too, is that the ERs are not interested in providing those bridges.
That's what we're trying to figure out.
Yeah.
We have a question from the chat.
Sure.
Is peer coaching integrated into the care?
So it is not, unfortunately, right now. We do refer to the Serenity Center on a very regular basis. And, that's something definitely for us to discuss, is how do we, how do we integrate with them? But at the moment, they're not. We've just referred.
Lindy, go ahead.
You mentioned the actual teaming of patients, that when folks get together and you go over all the
Yes.
clients.
Yes.
How often does that happen and how long does it take and how many people do you cover in that period of time?
Let's see. So those particular meetings where we have absolutely everybody around the table are monthly. I would like for them to be more regular. We do have more regular meetings where we're supposed to be talking about other things, but oftentimes we talk about patients. And of course, we do as a behavioral health team, so where there are not, providers around. So we had IDT.
IPT is more programmatic, more a meeting where we try to talk about issues in the program, any changes we want to make, those kinds of things. And then we have kind of our individual, you guys have an individual program meeting where you talk about your patients.
Yeah, that's weekly.
That's weekly.
Yeah. So my apologies, Lindy. As like a whole, like the mosh of us, we do that monthly, and really weekly, for the individual clinics. We're talking about patients and we're talking about operations and those kinds of things. So Sometimes it takes kind of a long time. It really depends on the complexity level. You know, I mean, certainly if we don't talk about a patient there that we're concerned about, then we'll need time to do that, when the meeting isn't around, or isn't occurring. So
how long is that meeting scheduled? I mean, I understand you have all these other ways, I'm not being critical, I'm just trying for people thinking about how to do this. What's it scheduled for?
An hour. We all sit down and we have lunch together.
Okay, so over lunch, and does it, I mean, do you try to cover, like, all the cases, or is it designed for, like, this complex that we need to talk a lot about?
Mostly complex cases and patients that we're really concerned about. So we don't generally talk about successes, which we should, you know, because there are a lot of successes going on.
The last meeting, we just started at the top of our list, and
That's what I
We went down.
whoever who was responsible for each case just went over doing good. The doc said, yep, doing good, this is the current treatment goal, and then we just went down through them.
That's what I was wondering, and then you spent time on the ones that there were challenges.
Yep, anybody, and then when we got towards the end and we could see we were getting closer on time, people said, okay, we need to talk about this one's on my case, this one we need to work on, and we kind of identified those topics that,
I guess that, maybe ties into my question. I was noticing, in your case, when you talked about referral, follow-up, and care coordination, that unfortunately you don't have, it sounds like an Anne Marie that is able to keep their eyes on everything. So is it those meetings where you're able to go through the different types of referrals that have happened and those types of things?
We do actually have an Anne Marie. Her name's Lori. She's our team leader. So she usually keeps an eye on, you know, on who's doing what and, you know, making those phone calls and following up on referrals. But also she works really closely with our case managers too. Case managers tend to do the referrals and do the follow-up, and, you know, because they have the opportunity they do this while they're sitting down with the patient. So oftentimes, you know, referrals to outside organizations aren't happening without the patient being there. You know, if it's within, you know, we talk about it and, you know, I mean, the actual electronic stuff is going on. So it's kind of a both and, you know, I mean, yeah, I think that answers your question. Yeah.
I was just gonna say, for SAMHSA, the funder of, a couple of the MAT grants in the state, like, their definition of success is not complete recovery. I mean, it's like at least 65% of patients will report decreased opioid use, and it's more around retention and treatment. So, you know, if you ever wanna pull that out, I think it's a very reasonable, you know, it sort of sets an expectation that's a lot more realistic than, you know, I mean, how many people enter alcohol use, misuse treatment and attain sobriety the first time? I mean,
absolutely.
You know, and we just sort of have these unrealistic expectations sometimes. And sometimes with MAT, people can think, oh, it's going to be so much easier with MAT. Well, it's still a very complex, relapsing, you know, disease. So.
Absolutely. And excellent point. It's something that, I mean, we're going to continue to have conversations and look for opportunities. And I think that's part of what it is. I mean, I think that there were a lot of these conversations that happened when the program began 3 years ago, and that we all get complacent, right? I mean, people's thoughts kind of return to what they were before. They've got confirmation bias, and, you know. So we look for teachable moments. Anytime we're talking about the programs, we're talking about what the successes are and how we're reporting them out. And, you know, we're talking about complexity of cases and really emphasizing that these are your patients too. You know, I mean, they're not NCRC patients, they are WEAKS patients, they are members of the community. So yeah, I mean, that's a great point. And we always look for those teachable moments to kind of remind people, oh yeah, that's right, you know, this is, you know, a very different disorder from what you deal with. Actually, a lot of the medical, or some of the medical providers have, Dr. Nielsen in particular, you know, has a way of talking about it that's very, you know, he's kind of got this analogy going on. He's just like, look, you know, would you, if you had an insulin-dependent diabetic and they went and had a donut. Would you cut off their insulin? No, you would not. So we don't cut off Suboxone. We don't do that. And, what was that?
I say the same thing.
Yeah, so it's, I mean, it's helpful when we all talk and we can speak each other's languages. You know, because I talk about social determinants of health, and I talk about, it's just a little bit, and behavioral health happens slowly. And then, the docs can be like, well, look at this, so. Did you want to say something, Sean?
I was just gonna say, I would add too, as starting at it from the ground up, we got a ton of resistance from the community. We got a lot of backlash about, you're bringing these patients into our town, you're gonna put them next to the senior center, that's not okay, you gotta, and so originally it was, you have to have these clinics off-site, we can't have them at the hospital, these are dangerous people. And then we got to a place where we could have them in the bottom floor, and the clinics are in the bottom floor, and then we kind of grew that space and slowly just infiltrated the primary care practice. So then they were like, okay, we'll do it in the evening. And now they built a separate space in the new primary care office. They have their own hallway, we have bathrooms with the observation windows built in. And so now we're there, right? And our patients sit in the waiting room with everyone else, and so it's much less stigmatizing. And so on a program level, that's success in changing those stigmas and kind of integrating into those practices.
Absolutely. Actually, it's a great story to kind of, to build off of that. I mean, I saw a patient yesterday evening who was fresh out of the ER for alcohol dependence, and he had gone and saw his primary care twice or three times that week. And she said, it's time. We really have to do something. I know you've had treatment before. We really have to do something. I really want you to talk to the people in the NCRC. And she sent him right over to us. And we were able to see him within a day. And I happened to be there seeing patients at the same time, and so I was able to do a warm handoff, able to pop in and say, hi, you're going to be seeing me for your intake tomorrow. So in terms of that integration, it's water on rocks. Sorry, go ahead.
That's okay. So when I started in Concord, we started with patient zero and kind of built the program. When I took a position at Elliott, we tried to build a program around a panel of about 100 patients. So part of what I did in the beginning was review patients' charts who were on the physicians' panels and try to sort out who's stable, who's not stable, who needs more support. And one of the things that really brought to light to me was sort of what you were referring to. So in some patients' chart, you could almost see after a while when they started treatment, because you see ER visits, urgent care visits, missed appointment, phone call from the patient, ER visit. And then they start treatment, and then you see all of that stuff. And Epic is the EMR they use, so it's easy to discern the difference in encounters. And it's definitely something that I think is really great to point out to providers too, because we don't have those measures yet, really. I mean, they take care of people with chronic illness all the time, and they know that about chronic illness. They know that not everybody's going to take every recommendation for treatment or follow their treatment plan, 100%, and they don't withdraw treatment or even think to withdraw treatment. And they do develop a lens of looking for success, if it's a diabetic. Maybe their blood sugars last year were in the 300 range, and now this year we're down to 249 or 250 consistently, and they can see that. If we don't help them to sort of see those things, I think it's going to take longer for them to understand. I love that Southern New Hampshire Medical Center is inviting the providers through.
Absolutely. It's great. I mean, and I know that we extend it to our providers too, and we've had fewer takers, and I'd love to talk to you guys over at Southern New Hampshire Medical and see how you guys got so many people to be able to go through. But it's interesting because I think at this point, and may disagree with me or agree with me, my compatriots from weeks, but I think for the most part, primary care is really seeing the value and understanding, you know, the impact on that. I think that the specialties, it's a little bit more challenging, but it's because they're in a different way, you know, they're treating people very differently. So, you know, primary care, they have an idea because they see their patients all the time, and they see the improvement as they've gotten treatment. So, you know, I think it's a lot of bringing the specialists on board and saying, okay, you know, this might not be your specialty, but it has a huge impact on your patients that you're seeing on a regular basis.
And one of the things is with primary care, when so many people come only for substance use disorder, and then you bring it to primary care, and because we are doing both, sometimes with the same provider, the good thing is when the patient begins to do well, we treat the Hep C, we educate on other issues. Some of them, they are going into PrEP because we have to prevent HIV. So we are trying to integrate everything in primary care. And this is good for the patient because they begin to feel that it's part of other disease. So, and not that it's something that is outside of the world that nobody will understand. So, and always say, when they come and say, oh, I'm clean today, or say, no, you're clean all the time. you are sober. You take your shower every day, even if you use. You know, and they begin to understand that it's not something that they have to be ashamed about, and it's good for them. So it's very important.
The other measure with primary care is, most of the primary care organizations in New Hampshire, they have some kind of value-based payment arrangement with their carrier. So they know that, you know, decreased hospitalizations, decreased emergency room visits drop directly to their bottom line and the shared savings they have.
Sure.
So that's another way. If they look at that and those numbers, then that also helps show success to them as well.
Definitely.
Then they get more invested in working with us to treat these folks.
Jennifer, did you have any other questions that you wanted to hear people's perspectives on, or other kind of topics you wanted to chat?
I don't think so. I think I covered it.
I think we have one more question that came in on the chat. Wondering how your team is practicing self-care to avoid burnout or reduce stress.
That's a great question.
We're going to suffer after.
Yeah, that's true. Yeah, there we go. Thank you. Thank you. Well, I mean, God, I don't even know how to answer that question, which is saying something, right? So we have a pretty close team, even though we're at very different locations. You know, one day a week, we're pretty much all in the same place, with a few exceptions, but we're pretty much all in the same place. And so that's helpful. You know, so we make connections. And I think that all of us are concerned about burned out. You know, I mean, we see it in ourselves. Not that anybody is burning out, but we see the strain, we see the stress, because there is a lot of it. And so we tend to be very sensitive to each other. So I think that there's definitely huge interpersonal, you know, skills that occur there, and how we react to each other. Also, we tend to support each other with going home on time, making sure that we're scheduling within boundaries. Don't say anything, Shauna. I have a bad habit of scheduling lunchtimes in at 5 o'clock, and generally that's really that's frowned upon gently, kind of like, no, don't be doing that. You know, make sure your time is your own. You know, and we have our practice manager, Christine, is very good about getting after us if we're doing that too much. So I mean, those are some small things that we kind of do for each other. Always looking forward to getting more suggestions, so if people have more suggestions. For a little while, we were doing AccuDetox on each other. That was pretty helpful. Maybe we need to do that again. You know, group massages we're up for, I don't know. But if anybody has any suggestions, I think we're open to hearing them.
I think this is a good stress, help everybody handle the stress.
The community of practice?
Yeah.
Yeah,
Thank you.
absolutely. Absolutely. Yeah, puts us on the same page, and also, you know, so I'm not alone, you know.
I know in my work, no matter where I'm at a new, organization now, but I always try to check in with my team members. How you doing? You know, just, especially, you know, if they've had a rough day and just offer to help, you know.
Yeah,
I think
yeah.
that just.
That's great. We do that a lot. I mean, unfortunately, even though we're not all in the same location at the same time, we do have an instant messenger, which is more responsive than email. You know, I know Shauna and Lydia both routinely check in on me, and we do the same thing for each other, and just how are things going, especially, you know, especially because there have been a significant number of changes over the last 6 months or so for our organization, which have been challenging. So yeah, it's pretty.
I think one of the keys to managing burnout is to talk about it.
Yeah.
To acknowledge it, because it then opens it up and nobody feels alone about it. Nobody feels that stress all on their own shoulders. And I think that it provides us an opportunity to support each other. It provides us an opportunity to learn how other people manage stress. And very much like you, we check in a lot with each other, and we talk about, you know, the difficult people, or, you know, a patient will leave and we'll go, and we'll get up from our chair and we'll go to the next door and we'll open it up and we'll go in and we'll just sit down, you know. So there's a lot of that kind of internal support, but I think as long as it remains a subject, and that it's always talked about, that it's safe to talk about, then I think that's a huge thing.
Yeah.
We have the same stigma ourselves, right? We're not
Exactly.
we don't even talk about it.
No,
It was very good that we didn't feel that.
Oh,
way.
yeah.
We're telling patients and clients to talk about it, and we're like, oh, good.
Right.
And it's
Just an
important.
open conversation.
Yeah, it's important to, you know, when you see a patient that is very conflicted and maybe it's heavy, it's chest, sit and talk with another person, another colleague over there. I saw this patient and discussing the patient, and I said, and try to bend the idea about how you're gonna manage the patient, or is kind of reassure that you're going to do the things that you need to do, but with other people around always, and it's important. It's
We
not
talk a
like
lot.
having the whole responsibility by yourself.
Yeah.
We talk a lot to our patients about self-care.
Yeah. Oh, yeah.
A lot to our patients about self-care, especially as they progress in their recovery. We talk a lot, all of us do with our patients about self-care.
Great. That's great. I think too, I think this is kind of what you're saying too, we consult a lot too. So it's not a shame to say, I don't know what to do with this person. You know, I am at my wit's end or whatnot, you know. So, and that's super helpful too. Because, you know, you don't feel like you're carrying it on your own, or like you're responsible for whether this person uses tonight or not. You know, to talk about that, and to recognize it, that it's okay to talk about it if you start to feel those boundaries softening. You know, we talk about boundaries quite a bit too, to keep those up. And personally, I'm taking a mindfulness-based stress reduction course, so, you know, that's...
I think too, it's a measure that we don't really have yet too, is sort of what is capacity. You know, we have all these new roles, everybody's functioning in different roles, that we don't have a lot of information to know, you know, in a clinic maybe like your clinic, where the patients have high acuity. What is a patient load? When do you say, no, we can't take on anymore? You know, versus maybe a primary care provider who's taking care of 10 patients, or, you know, so those are things I don't think we've even begun to start to talk about, you know.
Absolutely.
We talk about burnout, it's probably a really important thing for us to think about.
Absolutely. And then the struggle, and in terms of burnout, the struggle between capacity and need, you know? I mean, because we might be at capacity, but if there's 5 other people who are high need and they're gonna die, we're gonna take them. And there's that responsibility again.
Yeah, and then you have the other, because these patients are very challenged in follow-up, and they don't show. But when they don't show, the last minute, they call and they say, I don't have any more spots and I need to be seen.
Yeah.
And when you put the boundary that is said, not today, I'm not going to see you. Today, you have to learn to begin to. And it's a very difficult decision. And sometimes the thing is, I fight and my wife throws my Suboxone in the toilet and I need all these Suboxone again. And you don't know how much of this is true or not. And it's very challenging because nobody wants what you write be on the street, but I don't want anybody to detox because what happened is true. So you really need to know your patient really well to go into this fine place.
Yeah. Any other last comments or questions for Jennifer or anyone? So, thank you, Jen, very much.
Thank you.
So there's a couple things that I just want to say about your evaluation. So, we made some decisions as this was all happening. You guys were having such great discussion, that we didn't get to the activity today. But just to kind of let you know what that was going to be like, we were going to have you all kind of map out how it works in your practice, kind of using the models that Anne provided in her presentation that you have printed separately, nice and big, so you can read them. So something to consider as you go back to your desk, we were going to kind of look at, is it a strong line, a dotted line, no line for your connections with these people, and then kind of taking the learnings that we had through our great discussion today, thinking about how to strengthen some of those lines and some of those connections. But since we didn't have time to it gets me kind of into a good transition about your evaluations and your upcoming meetings. So I want people to notice on the second page of your evaluation, you guys, if you've been here a lot, know these are typically pretty similar, but we did add in some new topics for future meetings that we want you to consider in your rating. So the planning team went through the list and kind of thought about, how things are changing and how a lot of your practices are progressing, and tried to identify a few topics that we think might be of interest to you, but we want to hear from you. So those include utilizing long-acting medications such as Sublocade and Vivitrol, using technology for patient support, coordination with jails, prisons, drug courts, other kind of mandated treatment situations perhaps, and working with specialty populations. And then you'll see I did really big text in bold, so please specify on that one if you are interested in that one, which population. Something else that if you think of it or have a comment about kind of at the bottom of your evaluation is, do you like kind of the format where over the last couple of meetings we kind of did a deep dive, right, into topics related to treatment planning. So we did kind of an overview about ASAM, we discussed discovery and relapse prevention and care planning at this one. So we've kind of been going deeper than we might typically over a series of meetings. And so we're wondering, do you like that? Do you like to spend more time on something and kind of, grow the learning on a single topic, or do you like kind of changing it up every time? So if you have an opinion, feel free to put it in the evaluation, and we'll review that in our planning team meeting. And I will just say to the topic about billing, Lindy had brought it up, I think, at our last meeting, and just letting you guys know an update that we are still working on that, are still planning a future meeting on that. Right now it's looking like June. So stay tuned for that exciting news.
That kind of breaks down like the H codes versus the behavioral health codes, when you can use more than one code, what codes are appropriate, like kind of billing coding.
So I don't know, but what I do know is that the reason that it's kind of so far planned out for June at this point is because we are starting to engage people that have much more knowledge and sense of these things than we do, and really start to dive into what are the questions. Are the questions, when can I use multiple codes? What's the difference between these codes?
I put it on here.
And trying to get you answers there, yeah.
Yeah.
Lindy, do you want to add something?
Just gonna say, our next step is to actually get out to some practices and take a look at what's going on and where the problems are. And then the meeting will address the problems that have been identified in the practices.
You wanna come to the North Center?
At least I feel that that's the case.
You don't know what you don't know.
Yeah.
Exactly, so now we're getting people who actually even have any idea what you're talking about.
Yeah.
Who have expertise to go look at that.
Yeah. So we were in
So
that
if there is a practice that really does feel like you would be a great site for someone to come look, like, sit down and look through.
Yeah.
So please, let Addie know.
Let me know, email me.
Yeah.
Yeah.
Because we have an
Can you just add it
idea,
on their evaluation?
and obviously they can't get
It's not,
started.
their name's not on it. Their
Oh,
name's not on it. So that's pretty much, so I did want to note that, in April 9th, we don't have this room available because there's a meeting that kind of butts up too quickly that we wouldn't be able to turn the room around and kind of be settled for you guys. So we had done a poll at a past meeting, that people wanted to make sure to keep the same time and stay in the Concord area, so it'll just be hopefully somewhere within 10 to 15 minutes from this location, but we'll let you know, and I'll make sure that it's bolded, and I tell you 100 times, so but just note that if you go into autopilot on your way here in April, that might be a challenge for you.
Walk into the room.
That
would be
Sit down, So, remember to use the Google group, remember to turn in your evaluation. Melissa will check you off in the back, so while your evaluation doesn't have your name on it, she'll check off that we got it, and then you will get your certificate, and you'll get 2 CEUs for that, and let me know if you have any questions. And thank you all for your great discussion today, it was really awesome.
Thank you.
And thank you to everyone on the phone, we'll end the meeting now, and you can get back to your day.